I'm back up. Excited. All right, so we covered quite a bit of information. My second talk, as Clayton just mentioned, is going to be the idea of alternatives to a total joint replacement. So instead of replacing the whole knee, the kneecap, the end of the thigh bone, and top of the tibia or shin bone, what other alternatives and who would be good candidates for these quote-unquote less invasive procedures for knee arthritis. So as we mentioned, the two types of cartilage in the knee, the one we're specifically focusing on that's affected by arthritis is, again, that joint or articular cartilage, which is made up of chondrocytes or cartilage cells. All right, now you have to help me. How do I do that? Yeah. Got it. Come on. Okay. So, as we mentioned several times, this cartilage cannot cannot regenerate itself. It'd be great if we can. So how do we address this? Well, we divide treatments for rough torn cartilage into what I call non-biologic treatments, meaning we're simply getting rid of the bad stuff. That's what Dr. Moore addressed. We call that chondroplasty when we go in and we shave the rough torn cartilage, but we're not doing anything to regenerate cartilage. There's a technique we call microfracture that is not regenerating the cartilage, but is regenerating some scar tissue. So a microfracture, and I think I've got a picture of what it comes in a second. We'll talk about that just in a second. The other option would be to somehow restore or transfer cartilage cells. So we would consider that a biologic treatment, meaning we're trying to really recreate or restore biology to the end of the thigh bone where the cartilage is damaged. And there's several options for that, which we'll discuss. So again, this non-restorative cartilage technique where we're simply trying to get rid of the bad stuff, create new stuff. Two options, this abrasion chondroplasty, so this is rough cartilage underneath the kneecap, and we're simply bringing in the lawnmower to shave the cartilage. So that's an articular shaver. It has little blades on it. Very typical part of a knee arthroscopy where we would get rid of or try to smooth torn cartilage. But again, we're not putting cartilage back with this technique. If the lesion or the injury to the cartilage is a certain size, meaning relatively small, about the size of a penny, is about all we can treat with this. There's a treatment called microfracture, where we're trying to do what's quote unquote a healing response. We're trying to get the body to heal or replace cartilage. And the way we do that, you take a little pick and you poke holes in the bone or a drill, small drill, and the idea being is that below that bone is bone marrow. And the bone will bleed, and those tissues, those bone marrow cells, have the ability to create some scar tissue or fibrocartilage. So 6 months, a year down the road after we scope this knee, we might go back and look in it, and you would see this bone is covered with this white stuff that looks like cartilage, but is really scar tissue, but at least it's covering that exposed bone. So that's a very typical something we might do at the time of a knee scope if we see a cartilage injury such as that. Those aren't really very sophisticated. They're kind of sledgehammer treatments. So then we can become more sophisticated, and we can start talking about restoring or replacing chondrocytes, and there's several options available. So this is a picture. This is a gross picture, meaning gross as in it's gross, but meaning it's not a scope picture. This is an open surgery. You're looking at the end of a thigh bone that has this cartilage lesion. One technique we can use to fill that in is to borrow good, healthy bone and cartilage. These bone plugs you see that we take from a normal area of the knee and we fill the defect. It's like filling in the pothole on the street. So now we have nice cartilage cells and bone beneath that have covered this area, okay? There's limits on who's a good candidate for that. It has to be an isolated lesion, and again, it can't be so big that we're taking huge bone plugs from somewhere, creating a problem somewhere else. So the size lesion, we call those lesions, or size of injury, is really not bigger than a nickel or a quarter, because once you start getting bigger than that, again, you're causing more damage somewhere else. We can also fill these in with cadaver bone, so what we call allograft. Dr. Moore mentioned that term. So we can either fill these defects with cartilage and bone from myself, or we can borrow it from donor tissue. Getting even more sophisticated, you can do something called ACI, or articular cartilage implantation or chondrocyte implantation. This is a technique where it's a two-stage procedure. So if somebody has a relatively large cartilage injury, but the rest of the knee is good, we can go in and harvest some cartilage cells or cartilage tissue from the patient. We can send it off to a lab. The lab takes those chondrocytes and cultures them. That means they take 500 cells and make 5 million cells in solution. That takes several months, and then they send it back to us, and then we go back into that patient and do what's called ACI or Carticell or Macy. There's a bunch of different names for it, but the idea is the same. We're sewing a patch of tissue, and beneath this tissue we inject those chondrocytes. So you're transplanting or putting cartilage cells in the area of damaged cartilage, putting the patient's own natural cells which have been reproduced to fill a big defect. So that's the whole end of somebody's thigh bone. Little bone plugs wouldn't really address that. There are some big downsides to this procedure. It's not done much. Number one, requires 2 surgeries, so that's not great. And number three, four, it's crazy expensive. It's about $20,000 to $30,000, and insurance doesn't cover it. So you don't see this done very often, but it is available. The latest, greatest catchphrase in all of medicine is stem cell therapy. Stem cells can do everything. What are we going to do with stem cells? Well, lots of stuff. What is a stem cell? A stem cell is simply an embryonic or mesenchymal, that's your big word for the day besides contemplation, mesenchymal. So these cells who have not decided what they're going to become. And so we can take embryonic cells and try to differentiate them, meaning make these cells direct down a path to become cartilage. So this schematic on the right side, you see this poor little purple cell that nobody wants to be when he grows up. We throw some signals at it through chemistry and science, and voila, it decided to become bone, muscle, cartilage, fat, spinal cord. We're trying to use it for all these things. I would tell you at this point it's really still pretty investigational. We don't know how to take a stem cell and make it a cartilage cell or bone cell really well. It's out there. It's being done at high expense. I think in the next 20, 30 years it's going to become much more understood. But for now, you'll hear about it, read about it, but really in practical matters, it's not being used much to restore cartilage at this point. So those are great ways to replace cartilage. We see quite a few patients who come in and they have this deep pain. We're going to talk about another procedure here called subchondroplasty. We'll see patients come in, they have knee pain, either on the shin bone or thigh bone. Their x-rays really don't look super arthritic. You get an MRI study and you don't see a severe cartilage or meniscus problem, but you see an MRI study that looks like this. So normally on MRI study in this sequence, the bone is nice and black, and it should all be nice and black. So the top of the shin bone, the tibia, you see this bright white signal, and on this image, this is the end of the thigh bone, the same thing, this bright white signal. And we say, well, what's going on there? What's happening? We call those bone marrow lesions or bone marrow edema or a bone bruise. And what happens in these patients is typically 50, 60, 70-year-olds. They don't often have an injury. I refer to it as they have a crack in their foundation. So the bone structure is the foundation for the cartilage. And as we age, we see people get these bone marrow lesions where the structure of the bone is seeing too much stress. We might call it an insufficiency fracture or a stress fracture. You may have heard that term, stress fracture. It's where the bone's not broken out of place, but the foundation of the bone is suffering and not holding up. These lesions can be very painful, and you say, well, boy, it's just this one part of the knee. Does that need a knee replacement? Injections haven't worked, medicines haven't worked. Is there something we can do to fix the foundation of the house? You call AFS. For the knee, there's this procedure that's come out in the last 2 or 3 years called a subchondroplasty, and it's been really a nice tool we have. So the idea is that with this procedure, through tiny little poke holes, we take a cannula or a device and we put it inside that area, which we've mapped out on MRI study, and we map out the time of surgery, where it needs to go, and we're injecting this big white stuff you see here. It's called calcium phosphate, which is a normal part of our bone structure. It would be just like putting cement in your foundation at your home to raise it back up. And this is an amazing way, or a very effective way, to treat pain for the right reasons. But we have to make sure the pain is coming from these bone marrow lesions or bone bruises. 5, 10 years ago, we really didn't have a great option for this other than tell people to take their weight off it and let the stress fracture heal. So this subchondroplasty procedure is really a nice additional tool in the right patient, as we said. If those things don't work, and this nice young lady over here said, well, hey, if I have pain only in one part of my knee, do I really need a full knee replacement? And that's a great question. So the idea, if someone comes in and we divide the knee into three parts, the medial compartment, or the inside of our knee, the lateral compartment, and then the kneecap compartment, a lot of folks have isolated or maybe one or two parts of the knee that are involved. So the most common would be the medial compartment. So the inside of the knee tends to be what we see most involved. So you can see this young man is bone on the inside of their knee. The kneecap tends to be the next joint that's most frequently involved. It's fairly rare that we see isolated lateral compartment disease, but it does happen. And again, what options do we have for the 30, 40, or 50-year-old or older who says, boy, only one part of my knee hurts, why would you throw the baby out with the bathwater? Well, you may not. So partial knee replacement becomes a good option. Some of the advantages of partial knee replacement, where we're only replacing the bad part of the knee versus the full knee. Well, number one, it's less invasive. So instead of a little larger incision, we can sneak through a little 2 or 3 inch incision. A smaller incision that leads to less morbidity, so pain, less pain, lower blood loss, maybe shorter recovery times, although total knees can recover pretty fast. Shorter recovery times. And one of the nice advantages that patients tell us when they're young and active and playing tennis and skiing and basketball, these kinds of things, is that it preserves that important ACL ligament. So patients feel like oftentimes with a partial knee, they'll say their knee really feels stable because they have that normal ligament that stabilizes the knee. That is one key requirement. You have to have an ACL ligament in order to undergo a partial knee replacement on the inside of the knee. So that's called a unicompartmental or partial knee replacement. So the medial compartment, as we just talked about, that's what a typical partial knee looks like. You can also replace just the kneecap compartment. So if somebody has isolated patellofemoral or kneecap disease, such as here, so you see the implant, which is this device up here, where we're simply replacing the poor area of the knee behind the kneecap and putting a kneecap in. So that's what that looks like on x-ray. I don't have a picture of a lateral compartment, but imagine this piece sitting over here. That's what a lateral compartment knee replacement might look like. There's just some additional pictures there. Thank you. Any questions, discussion? I think we're going to save those to the end. Just kind of a brief mention about the process of a partial knee replacement. It's inpatient surgery. I'd say 90 to 95% of the patients go home the next day. So 24 hours in the hospital. Therapy starts immediately. You're up walking the day of surgery. We have some amazing techniques that Matt may talk about for pain control so that people are able to walk up, stand up, walk the day of surgery. Full recovery from a partial knee replacement can be 2 to 3 months. However, people ask, when does the pain go away? It's really pretty quick. So within 2 to 3 weeks, that arthritis pain is gone. They're having they're having surgical pain, but that's typically well managed. Ryan did a great job mentioning that not every surgery has risks. Risk of blood loss, infection, damaged nerve vessels, those things are all extremely rare. If you take all the risks combined with partial knee replacement in the right patient, all those risks are well below 1 or 2%, so very, very low. I guess we can get into more questions, discussion later, because Matt's going to talk about the final answer, which is total knee replacement.
So, final topic of the day, total knee replacement. Let's see. Here we go. Okay, so I have 4 basic questions that I want to answer for you today. Number 1 is who needs a total knee replacement? Number 2, what exactly is knee replacement surgery? I want to answer what you can expect from surgery, and then kind of go over the risks and outcomes at the end of the talk. So knee replacement is typically reserved for patients with osteoarthritis who have failed conservative treatments. So it's very important to at least attempt to go through those conservative treatments, whether it's oral anti-inflammatories, corticosteroid injections, or the viscosupplementations or the hyaluronic acid injections that Brett talked about earlier. It's very important to at least have tried those before you just jump into a knee replacement. You don't have to have typical osteoarthritis. These surgeries can be done for things like rheumatoid arthritis, post-traumatic arthritis, or any number of degenerative causes of knee pain. And so on the x-ray here, what you see is typical bone-on-bone arthritis. It's affecting primarily the medial compartment, which is where the bone is touching. But then when you look here, and I think it probably projects a little bit better on the TV screens, when you look at the lateral compartment, you you'll also start to see some bone spur formation out there. So it lets you know that the arthritis is not just affecting one compartment in this patient, but there's multiple portions of the knee that are involved, so it really needs a total knee replacement. Couple of questions that I get asked pretty often: is there an age limit? The short answer to that is no. Certainly for younger patients, you really want to put it off as long as possible. These knees, just like the knees that we have normally, they can wear out. It's a metal and a plastic knee. The plastic can wear out over time. Those I'll talk about later, they do typically last quite a long time. And you're really not necessarily too old for it. I don't put a number on you. I don't do this for a patient over a certain age. It's more about your physiologic age. Meaning that I see some patients who are 65 and are very ill and may not make it to 70. And then I see an 80-year-old that comes in and walks, 3 or 4 miles a day, is on one medication, and it's probably going to make it to 90. One of those patients is going to be a great candidate for a total knee replacement, being that 80-year-old, and the 65-year-old may not be, even though they still have the same amount of arthritis in their knee. And then I also get asked, is there a weight limit? This is going to be very surgeon dependent. Some surgeons will operate on folks no matter what their weight. Myself, I do have a limit on what I call the BMI, the body mass index. And that's a way to look at your weight in proportion to your height. And so there are good studies out there that show that once you get to a BMI of 40, particularly above 45, the risks of surgery start to increase significantly. Risks of things like infection, implant loosening, continued pain. And so when I see patients at a BMI above 45, that's when I start talking to them about, let's get this weight down and really try to decrease that BMI so we're decreasing our risk factors. And so for me, I would say that yes, there is a, quote, weight limit based on BMI. Some folks will bypass that and operate regardless. So again, that's surgeon dependent. The question that I ask patients when I'm talking to them about whether or not to have a total knee really is, does your knee pain rule your life? Are your knees telling you what you're able to do on a daily basis? Can you not shop at this store because it hurts too bad to walk in? Can you not visit this place because there's 10 steps going up and you just don't want to have that pain? Are you not able to sit in a chair for more than 15 or 20 minutes without feeling like you have to get up? If the answer to those questions is yes, then it's not necessarily that you have to have a knee replacement, but it's definitely time to see a surgeon and start that discussion and start going down or I should say working your way up that treatment ladder until you can get some relief. So the knee replacement itself is also referred to as a total knee arthroplasty, or a TKA. It's basically a surgery that simply resurfaces the arthritic joint. So in this illustration here, you can see that the metal components on the end of the femur and on the top of the tibia are simply resurfacing the bone. You're not taking out a big chunk of bone and putting in some type of bionic knee. The knee doesn't replace the ligaments on the sides of the knee. The ACL and oftentimes the PCL are replaced with this, but the MCL and the lateral collateral ligament, the LCL, are still there. And it does not replace the muscles or tendons. So it's just resurfacing the ends of the bone. There's 2 main goals of the surgery: to relieve pain and restore function. And the vast majority of the time we're able to achieve those 2 goals. So I'm basically just going to walk you through how we do the surgery. I think it's going to help you get a good understanding of what the procedure is and why it uses relief. So the incision just goes over the front of the knee. That would be one of the longest incisions I've seen for a primary total knee. They're typically much shorter than that, but just for illustration purposes, that's typically where the incision is made. Then you carry that down and you encounter the fascia or the capsule overlying the knee. And we do, most all surgeons here, what's called a medial parapatellar approach, where you just make an incision along the inside of the kneecap and carry this up and down along the tendon. And then you get your exposure to the knee joint. The patella itself is usually kind of flipped to the outside to allow for exposure to the end of the femur and at the top of the tibia. And so this is a pretty typical look as to what you would see during a total knee replacement. Now, once you have this exposure, you begin preparing the bones for the implant. So you do have to make little cuts on the bone for the implant to sit on there securely. We have guides that help us make these cuts very accurately, so they're pinned into place, and that guides the saw to make a very accurate, clean cut. So you typically make a cut off the front of the femur, and then then that gives you a nice flat surface. The next step in the surgery is actually sizing the femur. And so the implant companies that we work with have a number of sizes of these implants available during the time of surgery. And so that's how you know that, when we size it, we make sure that it fits your bone. So it's not just like one implant for each patient. So you size it, you make some additional cuts on the femur for that component to sit nicely. See, the cuts include a cut in the back of the femur, back here, the front, and then 2 diagonal cuts that we call chamfer cuts that allow for that component to kind of fit on it just like a glove. Once you finish the femur, you have to make a cut on the top of the tibia. Most folks use what's called an extramedullary, meaning outside of the bone alignment guide. You want that guide to basically parallel the tibial shaft. So as the tibia goes down to the ankle, you want that guide to be parallel, and your cut should be at 90 degrees or perpendicular to the tibial shaft. So you pin that guide in place and you make that cut. One of the things that I do after I get this cut is I actually have a digital x-ray machine come in. I take an x-ray and I can check to see if that cut is perfectly perpendicular to the tibial shaft. At that point, if it's not, I can fix it. That's something that's easy to fix in the OR, not so easy to fix afterwards. So we make sure that cutis nicely perpendicular, and then we look at resurfacing the patella. The patella, even on a total knee replacement, is not always resurfaced. Most folks do resurface it, but what you do when you're planning on resurfacing it is that you measure it. You want to know how thick it is so you can take off the right amount of bone, and then you kind of grab it with a clamp that tends to guide the saw and make a nice flat cut across the back of the patella. Drill small holes, and that's what allows you to fix this little plastic button on the patella so it no longer has arthritis or bone that could be painful. You always use trial implants during surgery. So you put the trial implants on, you want to feel that the knee is nice and stable, has a good range of motion, and that the components are fitting to the bone nicely. Once you've obtained that goal, then you put in the final implants. And so you can see here that the implants fit the cuts very nicely. They're actually stabilized to the bone using bone cement. And so once that bone cement hardens and sets, that implant is on the bone. It takes typically a fairly traumatic event for it to loosen. And so at that point, patients can bear weight. You don't have restrictions on the amount of weight you can put on the knee after surgery, so it typically lets you get up and walk fairly quickly. Here you can see that there are metal implants again. On the femur, there's a metal base plate on the tibia and a white piece of plastic in between. So instead of having bone-on-bone arthritis, which is what you see here on the left, there's bone-on-bone arthritis on the inside of the knee. You now have a knee where the joint is between metal and plastic. Metal and plastic does not have nerve endings. The joint where those two bones meet now can't hurt. Things that still can hurt are the tissues around the knee. You certainly have significant pain in those tissues after surgery. And also the bone does have some nerve endings. And so to alleviate a lot of that pain, we use injections during surgery to kind of deaden that area. So typically you have excellent pain relief right after surgery. You're able to get up and walk very quickly. So that's a good post-operative x-ray there. This may or may not be the x-ray of someone who's going to get up and talk to you in a few minutes. And here's the x-ray looking at both knees. You can see these knees are tending to bow slightly, and after surgery the alignment is nice and neutral and straight. And that's another goal of the surgery is when you have malalignment to straighten that leg. So expectations after surgery. How long will you stay in the hospital? It's typically 2 to 3 days. The average stay at Crestwood is 2.7 days. Will I be able to walk after surgery? As I mentioned multiple times, the goal is to get you up walking the day of surgery and work vigorously with physical therapy thereafter. Physical therapy is required after these surgeries. I tell patients that it's really kind of a 50-50 proposition. Half of the work is done in the OR, the other half of the work is done in physical therapy. You can do the best surgery in the world, but if you don't work hard afterwards, patients are not going to be really happy. You have to get in and work with physical therapy to get your motion and to recover well from this procedure. How long will it take to recover? Generally, most day-to-day tasks are normal for you at about 3 months. Full recovery after this procedure, we typically quote at six months to a year, but your pain is much better typically at about 6 weeks. Most folks come back in to see me at 6 weeks, off the cane or the walker, saying their pain is better, they still have some swelling, some pain at night, but generally doing much better even as early as 6 weeks. I usually allow patients to start to drive at 4 weeks. You do have to be off of your narcotics to get behind the wheel, which is important, but you can get back behind the wheel typically in about 4 weeks, even for a right knee. And then what restrictions will you have after knee surgery? Restrictions are pretty limited. You're able to do most any activity that we ask you to avoid high impact activities like running and jumping. Not to say that you can't do them, that simply stresses the joint in a way that it really wasn't designed to stand. So if you do those activities, you really run the risk of kind of wearing that knee out a little quicker than it would wear otherwise. The only thing I think patients typically complain of, most patients complain of after surgery, is a little bit of pain in the front of the knee with kneeling. So about 10% of patients say that they have no pain with kneeling after a knee replacement. That means 90% of folks have some level of discomfort over the front of their knee if you're kneeling down and putting weight directly on it. It's typically not really limiting for you, but it's something that you realize, put some pillows under your knee, and most folks deal with that very, very well. So risks of surgery, complications can occur, things like bleeding. You may have to have a blood transfusion. However, now we have some really nice things that we're able to do in surgery is limiting blood loss, and transfusion rates are very, very low. Infection is a big deal after these surgeries, and that can be fairly devastating. Take multiple surgeries to get rid of an infection if that happens. Fortunately, as you'll see in just a little bit, our infection rate at Crestwood is exceptionally low. DVT, which is a blood clot in the vein, a pulmonary embolism, meaning a blood clot going to the lungs, can occur. We do keep you on anticoagulation medicines, typically just aspirin after surgery to decrease the risk of that. Implants can loosen over time between the bone cement or the cement implant interface, which can cause pain. Some folks have stiffness after surgery or continued pain. Overall, these risks are very minimal. The rate at which these things occur is very, very low. So when we talk about the overall complication rate, meaning that you need to be readmitted within 30 days for any reason. It doesn't have to be surgery related. It could be that you end up with a stomach problem or a stomach virus 3 weeks after surgery, have to be brought back to the hospital. The national average for complication rate is about 2%, between 1 and 2%. Crestwood complication rate, as our latest numbers, is at 0.61%. So it's less than half the national average, which is a very, very good number. The infection rate, the national average, floats again between about 1 and 2%. Crestwood infection rate is right around 0.5%. That means 1 patient in 200 actually has any infection. And that's taken into account both deep and superficial, which is a very, very good number that we can be very proud of for those of us who operate at Crestwood. So general outcomes in terms of pain control, depends on what study you cite, but up to 95% of patients report satisfactory pain relief, and many of them are pain-free at 1 year follow-up. In terms of functional improvements, almost the same number report improved function, which means better motion, easier walking, much easier time going up and down stairs, and oftentimes even better sleep. In terms of survivorship, how long do these implants last? Between 90 to 95% of the knees that are implanted will survive for the first 10 years. If you make it the first 10 years, there's a pretty decent chance you're going to make it in 20. About 80% of knees that are put in will last 20 years. That's 8 and 10. That's a pretty good number for 20 years of pain relief. So I'm going to leave you with this. Total knee replacement gives patients back their mobility, and it really allows you to live your life without being restricted by pain. Joint replacement surgery, whether it's knee replacement, hip replacement, either one of the two, offers more patient satisfaction than almost any surgery that's done today. The only thing that consistently rates higher in terms of patient satisfaction is actually cataract surgery. So cataract surgery gives patients back their vision. So if you can imagine living life with no vision, it'd be very difficult. Joint replacement surgery gives you back your mobility. They both have drastic impacts on the quality of life. So if your knees are truly ruling your life, making decisions for you every day, I would suggest that you strongly consider seeing a surgeon, not necessarily to move straight forward with knee replacement, but begin climbing that ladder to get some relief, and this may be an option in the future. Thanks. So now I have a patient, Mr. Jamie Dodson's going to come up and speak with you. Those actually were his X-rays. So I've replaced both of his knees. When was the last surgery?
June 26th.
June 26th. So he's
June
really,
20th.
so really not very far out from him, and he has done exceptionally well. I just wanted him to say a few words, let you kind of hear the patient perspective of a total knee replacement. Then we're just going to kind of open it up for questions for us and Mr. Dodson.
So did I get the $100 afterwards? You gotta get your contracts right. I'm Jamie Dodson, retired Army, and I'm a guy that did a lot of hard things in my life, and I basically wore out my knees. Now I'm wearing shorts today, so you can see Dr. Clayton's work. See, it's not so bad, is it? Yeah, I'm going to come up from here. I'm shy. As you can see, yeah, they're not really that bad. This one is just a few months old, and this one was in April. So, not bad, huh? And you can see I've got flexibility and movement. So, let me just say what I've done today. Today, I walked 5.5 miles with my dog and my wife, not in that order. And yesterday, I walked 3 miles with my dog, and I climbed 200 stairs. And I've been climbing 200 stairs every day. And as well as, getting those legs back in shape, I've lost about 65 pounds. So that's worked very well for me. My experience in surgery is just as Dr. Clayton has explained. I was in Crestwood for the first surgery for about 3 days, and the second surgery, which was in June, for 2 days. I guess he figured I knew what to do, so he let me out. The biggest advantage is I have absolutely no pain at all anymore in my knees, and really have regained a lot of the mobility and the things that I like to do in my life. I'm 65 years old, so I'm kind of young for it in a way, but I was in the Army, I was a paratrooper, I was all those things, so I can basically wore my knees out. I'm able to ride my bike again. I can do 15, 20 miles without a problem, and it's been very good. The downsides of having the surgery is I travel a lot for business, and now I have to go through the X-ray machine because I have steel in me. They think I'm taking a bomb on board. I don't know what they think. But, so essentially, it's been good. My post-surgery experience was, the pain was fine. I had no problem with the pain. By about the end of the first week, I was able to get up and move around the house and do basically everything. I was moving slowly. I had my walker, but I wasn't walking the dog yet. 2 weeks, I was walking out on the street about a block, up and back. And then at 4 weeks, I was actually out walking a little bit with my dog. So I've had very good results, have been excellent in my case. The other downside, I would say, was a little bit of stiffness in my knees. And I think that Dr. Clayton's point about the physical therapy is really, really key. You just have to really work hard at it. The physical therapist that I went to said, you're fighting scar tissue, and you got to fight that. Just go for it all the time, keep after it. And even today, I'm still doing my stretching and a few exercises just to try and keep that mobility going. So I don't mean to take up all of your time. In my case, it's been a good experience. It's given me a lot of mobility. I was really back to work and pretty much doing most of my life, but at about 4 weeks. I can feel. It's funny when you move. It feels just a little bit different. It's not painful. It's just, that's interesting. But believe me, in my case, it's been very, very well worth the effort, the pain, and the surgical expertise of the team here. So, unless you have questions. You have questions?
Any questions for myself, Dr. Franklin, Dodson? Fire away.
If you replace, if you say you had your knee and it's bothering, but it's not bothering really bad, if you're limping on things that sort, does that mean you give a replacement?
So, his question is, if you leave a knee pain unaddressed that affects your gait pattern, can it cause problems elsewhere, specifically your hip? I guess the way I would answer that question is arthritis, as we mentioned, is a genetic disease. Your genes are all, for the most part, your genes in your hip are the same genes in your knee. So, a lot of people come in and their initial complaint might be knee pain, and then 2 years later, their hip's involved and their back's involved. So, does knee arthritis cause hip arthritis? Not necessarily. There might be some hip arthritis there already. Certainly, altered gait patterns, which is one thing Tommy, our therapist, really works hard to address. If somebody's altered gait, it can add mechanical stress to the hip, to the back. And so, we have people that undergo treatment for knee arthritis, injections, medicine, surgery, and those things upstream or downstream oftentimes can get better from a symptom standpoint. They may still have arthritis in their hip or back, but maybe it's managed better by correcting the knee. I hope that answers your question.
Another question. What limitations do you have if you're active in sports? Like playing, I play softball, and I've already had one knee replacement. Possibly I'll have another knee replacement.
Like I said, I would ask you to limit the amount of running and jumping that you do. For instance, I tell patients, if they like to play tennis, try to pick up doubles tennis rather than singles tennis. It's not that you can't do those things, but I would tell you that doing them, you're stressing that joint, that prosthetic joint in a way that's not necessarily meant to be stressed. So I think you're increasing the risk slightly of it wearing out a little bit sooner. But it's about getting you back to living your life.
Can you replace that joint, say you do that? Can you replace it easily enough, or is it like a blown out tire and get a new tire?
You can replace it, and the complexity or the difficulty of that replacement is really dependent upon what the problem is. Sometimes that can be a very straightforward, easy surgery. Other times you kind of have to start from scratch, and that's a much bigger procedure.
We want to, just like your car engine, you change the oil to maintain the longevity of a car. There's some maintenance involved in hip, shoulder, knee replacement, and some activity, lifestyle changes that you might want to consider taking into consideration, because a revision surgery can be very difficult. The number of times we operate on a knee, the idea of diminishing return. You don't, in my opinion, I don't want to have 4 or 5 knee surgeries in my lifetime. We want to try to keep that number one, have a great knee that rides you out the rest of your life.
And I do typically tend to see patients back every year after a total knee or a total hip replacement, just to look and see if that plastic is beginning to wear. If it is, and you change out that plastic early on, you can hopefully avoid some of those more complicated, complex revisions way down the line if you're not being followed up.
You said last 4 years.
Yes.
If you have both your knees bad, and you recommend both of them at the same time, or one and then the other?
I typically recommend doing one and then the other.
Okay.
And that's a discussion I actually had with
Yes.
Mr. Johnson, because
Okay.
he was planning to do both. Now, I'll tell you the reason why, because the literature that we have looks at patients who have had bilateral total knees, which means doing both surgeries in the same setting, shows increased risk of things like heart attack, stroke, mortality, dying after surgery. And so those are not risks that I'm willing to really take. And so I usually try to advise patients to do it in a stage setting, where what we did is we did the right knee first. He came back in at 6 weeks. I wanted to make sure that he was doing well. He was doing great. I think about 8 weeks after the first knee,
Exactly.
we did the left side.
From my perspective as a patient, I think it would be a good idea to do it at separate times, just for getting around the legs. I honestly think that if I hadn't done it both times, or both at one time, that my wife would have left me.
I think most joint surgeons have probably done. I've done bilateral knees at the same setting. It's a very select patient who's a good candidate for that. It's the 40-year-old that takes no medicines whatsoever, works in Saudi Arabia and is home for 3 months, and has this unique life circumstance where they really don't have 6 months of their life or 3 or 4 months of their life to dedicate to recovery. Matt's comment, the the one thing, bilateral versus Saint mortality rate, we need to sleep at night, I wanna sleep at night, know I did the right thing for a patient, and knowing that doing them at the same setting just puts you and us at risk, it really doesn't make a whole lot of sense except in those really unique individuals, so.
And when you stage it in that way where it's only, 6 to 8 weeks apart, it's really only increasing the recovery time those 6 to 8 weeks.
Yeah.
So it really doesn't change the total recovery very much.
Yes, ma'am.
I have a friend who opted to go to Vanderbilt for her knee replacement surgery, and the reason was that they did not split the quadricep. Can you talk to me about what you do differently? She said the recovery was quicker because of that.
So there are multiple approaches to the knee. The one that I showed is what we call the medial parapatellar approach. What they are probably referring to is something called a subvastus approach, which means you go in and rather than making this incision kind of up along the quadriceps, you actually go underneath the muscle here. There are patients that are good candidates for that. I will tell you that in my mind, that's taking a surgery that is relatively straightforward and you can make it very difficult very quickly. So if you have a very large muscle there, and this muscle is called your VMO, that makes that exposure, the things that you want to see every time you do surgery, very difficult. I think it's more important long-term to have the implant positioned appropriately than it is to maybe do something that gives you the first 2 weeks a little bit quicker recovery. So if I can't see what I need to see, the risk of me putting that implant somewhere less than the optimal position is increased. For instance, about 5 to 10 years ago, there was this fad for minimally invasive total knee surgery, where we were doing them basically through incisions just as small as you could possibly make. Well, what happened is we found that there was a higher revision rate for those surgeries because they were not positioned as well as they are when we make a normal, reasonable size incision. And so when you're kind of, the way I kind of address patients on that is I say, would you ask your mechanic to open your car hood